All right, terrific. Thank you so much. We are not going to be as deep thinking, pressing us all to the boundaries of bioethics. I apologize. That set a high bar. We're going to come back down to some nuts and bolts about privacy laws in Michigan and how they're impacting the exchange of information. So let me get started. So what I've been working on is a project that MiHIN asked me to do that looks at the laws, the statutes and regulations in Michigan that impact the exchange of information, health information among treatment providers. It was focusing on, as I said, statutes and regulations, and also doing some investigational interviewing of folks who practice in this area in Michigan, since I don't. And so oftentimes we find that looking at just the books, the statutes and the regulations only gets us so far. There's a lot in the culture of the legal community, so we also want to make sure we're speaking with practitioners. And why do we care about this? Why is this a project that I took on? I'm not a privacy law expert per se. I certainly am not a tech person at all. So many of the things you guys are talking about, I'm learning for the first time today. But what I do in New Jersey is work on a variety of policy initiatives with health systems reform. And one project I worked on was part of our state SIM grant, was looking at the integration of behavioral and physical health care in New Jersey, and why, despite grant funding from private foundations, despite support from the federal government, various programs were actually giving money back because they weren't able to integrate. They were having difficulty unsiloing the care despite support. There's strong support in the literature, and there has been for years, that integration of behavioral and physical health care really should be the state of the art. And it can actually not just improve care, but may actually save money. So it can support not just support multiple aims of the triple aim that we're all pursuing in healthcare. And yet, oftentimes, records remain siloed. And we found through our work in New Jersey that there are multiple reasons for those barriers to integration. For example, licensing regulations oftentimes are a barrier, reimbursement barriers, and the failure of state policies to support integration through reimbursement. But we also found that privacy was a barrier, and we identified some of those reasons in New Jersey. And MiHIN asked me to take a look at Michigan's laws and regulations and see if there were barriers there as well. So first, I'm not going to go into all the details. This report is not yet released, but I anticipate MiHIN will make it available at some point in the relatively near future. It goes through in painstaking, boring detail what the various laws are that impact the exchange of treatment information among treatment providers. So again, it is narrow. This is not looking at all laws that affect the exchange of health information in the state. It's not looking at mandatory reporting for child abuse, or cancer registries, or infectious disease registries, or immunization records. It's about the exchange of health information among treatment providers, because we were looking at it in the context of integrated healthcare. And so in that context, very important, even though this was a report focusing on Michigan law, always remembering that federal law is in the background as the floor, that states may be more protective of health, but they may not be less protective than what federal law establishes. And so the report will go through a variety of federal laws, of course, HIPAA and the Part 2 regulations that we've heard spoken about today, as well as some other laws that are not specifically about health records, but do impact the exchange. FERPA with respect to education records, to the extent there are medical records maintained by schools, and also some other laws that impact, including violence against women and other domestic violence-related laws. And general takeaway, generally you can exchange information among treatment providers, sometimes requiring consent, but certainly there's the support for the exchange of treatment information supported by federal law. So we looked at a range of Michigan provisions. There are statutes and regulations that speak to the exchange of information with respect to mental health services, substance use disorder services, regulations that speak to responsibilities of particular types of healthcare facilities and programs, different provisions that apply to different healthcare professionals. Sometimes provisions were about specific diseases and communicable diseases and the rules that apply to those records, or about specific services like abortion services and genetic testing. Again, big takeaway is very similar to the federal takeaway. The exchange among treatment providers is permissible under Michigan law, oftentimes without consent, but at least with consent. So why so many barriers? Why continued difficulty exchanging that information? And one thing the report identifies were that there are some ambiguities in Michigan law that might be complicating the exchange. And so the main highlights of the report, we'll go into some details in a minute to the extent time permits, but these are some of the major takeaways. First of all, encouraging the state to look at the existing statutes and regulations and look for opportunities to clarify and harmonize the provisions that govern the exchange of health information among treatment providers. For example, it lists several examples of types of laws in Michigan where there are, as elucidated in the report, opportunities for clarification that might be the existence of the ambiguities or the lack of definitions, for example, might be causing some hesitation among treatment providers to exchange that information. Another opportunity is to look at standardizing the policy regarding minors when not all provisions have a minimum age, for example, with respect to minors, for them giving consent to the release of their information, standardizing that so that there is consistency among providers throughout the state that might help clarify policies. I think very important to keep in mind is the need to, once you do this review and this clarification, this harmonization, is engaging in ongoing education and increasing transparency. I think that's one of the biggest obstacles. It's not the laws or the regulations in all these instances, it's people's concerns that they don't really know what these laws mean or what laws exist besides things like HIPAA, and they just don't want to do anything wrong. They don't want to violate the law, and they're confused by it. And so helping to educate and clarify whatever government can do through guidance documents, FAQs, to help to give that clarity. And also, I think this is not part of the report because it was very focused on integration of behavioral and physical health care, so exchange among treatment providers, but certainly there is a thirst in the community for clarification as to the extent to which exchange of information can be for purposes other than treatment, looking at population health initiatives and getting clarity on what is the appropriate role while protecting privacy and respecting privacy as an important goal at all times, but also thinking about the broader role for health policy and using this information. So again, I'm not sure how I'm doing on time, but to give you a couple of examples from the report of possible ambiguities or problems that we identified in Michigan statutes and regulations that might benefit from clarification. Section 748 of the Mental Health Code has a number of issues that could use some clarification. There's one area where it talks, generally the confidentiality provisions do not apply with respect to substance use disorder services. That's reserved for Chapter 2A of the Mental Health Code of Michigan. However, there's language about when the mental health services are being provided in conjunction with substance use disorder services, but the term's not defined, and so it'd be helpful to understand the relationship and what the rules in 2A versus 748, how to reconcile that, especially with respect to Part 2. If you have a Part 2 program with its own requirements with respect to the release of information, what if that program is providing co-occurring services? How do these sections relate? I think what most people in this room probably are familiar with is the more recent amendment to Section 748 that added subsection 7B, permitting the exchange, holders of mental health information could be released without patient consent, and you have the quoted language in the slide, trying to import the language from HIPAA, but not doing it exactly with the language of HIPAA, which now introduces some confusion. So you're permitted to release mental health records as necessary for treatment, coordination of care, or payment. And again, in accordance with HIPAA. But a couple of things stand out. For one, treatment is not defined. The Mental Health Code defines treatment as including SUD, but you see in the prior slide, Section 748 does not. As necessary is in this particular amendment, but it's not in HIPAA, so it's not clear what that term means for purposes of Michigan law. And I think the biggest question that all of us in this room have heard about from being here and knowing about this amendment is, what about this coordination of care, a term that is not part of the HIPAA treatment, payment, and operations exception? Coordination of care is used in the definition of treatment in HIPAA, and it's used in the definition of a type of healthcare operations in HIPAA, but it is not in the TPO exception, and it's not defined in Michigan law in this amendment. There's also a question, the next slide, I'm going to show you why that matters. But just to finish this slide, there's also a question of how much of HIPAA was imported into Michigan law through this amendment. For example, is HIPAA's treatment of psychotherapy notes also imported into Michigan law? And does this in any way affect the redisclosure limitation in subsection 3 of section 748 of Michigan's law? So to go back to the coordination of care issue, which I know from talking to folks here in Michigan for this project, there's a lot of question about what is meant by care coordination of care in the section 748 amendment. As I said, you see on the left-hand side, that's the HIPAA definition of treatment, which includes the word coordination twice. And on the right, you have the HIPAA operations definition, or one of the examples of healthcare operations in HIPAA. Again, you've got care coordination. Which one is Michigan law importing? Because if it's the operations exception, it comes with at least two other implications. One, the minimum necessary requirement will apply, and also you need to have the treatment relationship on both sides of the exchange. So these are important questions that need to be resolved. Again, I'm going to go a little more quickly through these slides because my guess is I'm going a little bit long, and I want to make sure we leave time for this open dialogue. But just a couple, the report highlights multiple examples, including some issues with the substance use disorder services provisions. I think the one that stands out here we have with respect to the definition of medical personnel. It's also not defined here as it isn't defined in Part 2, although there's recent guidance from SAMHSA that tries to give a little more help in understanding which medical personnel are included within this exception to the consent requirement. And a few other things with respect to the SUD provisions in Michigan law. I think the one that is most concerning is that the regulations, I believe, yes, the Rule 116 adopts the 1987 version of Part 2. And that is not automatically updated pursuant to Michigan law. So when you had Part 2 amended twice recently, 2017 and 2018, it's important for Michigan's law to reflect the most current version of Part 2, and so right now it doesn't. And you can see a few other differences listed here, including a potential preemption of state law, where state law permits substance use disorder services consent to be revoked, but it needs it to be in writing, whereas Part 2 permits revocation orally. So that the permitting revocation to be orally is more protective. I would argue that permitting revocation to be done orally is more protective of privacy, and so a less stringent state provision requiring it to be in writing arguably is preempted. There are also a couple of examples in Michigan law that are ambiguous with respect to the responsibilities of licensed professionals. There's some ambiguity in, for example, various mental health professional regulations, professional licensing regulations. Psychologists, for example, there's a consent requirement for the release of certain records described as information that's obtained during treatment, and it's not defined. The language is not defined. If that language is limited to psychotherapy notes, and in fact, Michigan law imports the HIPAA requirements of psychotherapy notes, then there's no inconsistency with Section 748. But if information is broader and it goes beyond psychotherapy notes, and this provision, this 18237, requires consent to release that broader information, then that's arguably inconsistent with Section 748's recent amendment permitting the release of mental health information without consent. There's also a strange provision regarding marriage and family counselors that refers to requiring consent for over 18. It seems like that must be a mistake. It's strange that it would not say 18 and over, but again, rather minor issue. Oops. Maybe I should go. Yes, I'm going to go for, this is a strange thing to me as well, too. There's permission for disclosure for treatment of HIV records for treatment, but the disclosure is not to include the patient identifying information. Now, sometimes a provision like that is included, but it says unless it's necessary for the purpose for which it was disclosed, which can make sense because it makes sense in the context of treatment because it's necessary to know who the patient is in order to treat that patient for whatever is the ailment, so it won't preclude release. But in this case, that's not the restriction. The restriction is don't disclose information identifying unless it's necessary to prevent foreseeable risk of transmission. I don't understand why Michigan law would permit a disclosure for treatment, but then say, but you can't say who it is who's got that ailment. It's not always going to be true that it's necessary to disclose the name only to prevent transmission. It may just be to treat that particular patient. Transmission is not relevant for that patient's treatment, right? The patient already has the disease. So that's a strange provision as well. And I should have done this slide a few slides earlier because I already see your eyes are glazed over. There are many other instances that are just somewhat strange that I think need some concerted attention, because what happens a lot of times is we have had the siloed care, right? We have had regulations or statutes that predate HIPAA or predate Part 2, predate amendments or a recent updating. And what's really important is now, I think, to take this opportunity to take this baseline report that surfaces and puts in one place the various existing statutes and regulations, and now take a careful review. There may be reasons that Michigan wants to have provisions that differ and are more stringent than federal law. That's fine. That can be a policy choice. I just think, just as we found in New Jersey, we want to make sure that that's a conscious decision, that it's not just a legacy of siloed systems. There's been a concerted decision to have distinctions. But where there aren't reasons for distinctions, I think weed them out, harmonize with federal law to the extent that's consistent with the policy Michigan chooses. And I think that might move things forward with respect to clarifying what can be exchanged, and hopefully there will be less resistance to the exchange of information that really does improve the quality of care for patients. And I welcome questions. I don't know how to close out.
Thank you, Tara, for that background. I now wanted to open up the panel to the other two presenters to kind of give some feedback based on what Tara discussed and add your own comments and experiences. Please feel free to also introduce yourselves and kind of share how your work relates to the topic of this panel, what lens it encourages you to take for considering healthcare and privacy and consent. Jim, I know that you also had a few slides, so if you want, you can start, and
Sure.
Your slides should go right after Tara's.
Or do we want to start with other questions related to the discussion we just had? I don't want to step on that, if there's any questions. All right, then.
Yep, I think we're good.
All right. Good afternoon, everybody. Jim Markwith. I'm the general counsel for the Commonwealth Health Alliance, but it's not my only client. Little background on me: I was in-house counsel for Allscripts Healthcare, and I have a background also. I used to be in-house counsel for Microsoft, and I happened to work for their IT section, which was their server and tools group, and also standards and strategy. So when I was at Allscripts, and the effort to create the Commonwealth Health Alliance came about, they were looking for someone who had healthcare IT background, but also standards. So they picked me. So I was one of the people that was initially chosen to help draft the founding agreements for the Commonwealth Health Alliance. So one of the good things about this, and I think from a timing perspective as far as discussion, we've been talking so far about state law, a lot about state law, and what the Commonwealth Health Alliance, what the intention is for the Commonwealth Health Alliance is to really solve the interoperability challenges that the nation has with regards to siloed electronic health records on a nationwide basis. So we've heard the discussion about challenges around healthcare in silos. The states are solving it, like MiHIN, very good job. When I looked at MiHIN structure today on the slides, they look very similar to the alliances structure on a different level. This is one of our earlier slides. It looks very similar to MiHIN's early slide that says, here's the challenge we're trying to solve. And so I'm not going to belabor that slide. It's the same problem. But the alliance's solution is similar to MiHIN's solution. It's a centralized hub and spoke type of arrangement where the alliance is the central organization that is promulgating interoperability standards for electronic health records on a nationwide basis. So like MiHIN, we have agreements in place between us and our members. Our members have grown to over 80 members now, including Cerner, MiHIN, HIMSS, McKesson, Change Healthcare, Greenway, Athena Health, 80 members across the continuum of care. So it's grown pretty rapidly. Also the Social Security Administration and the DoD. So one of our members is MiHIN, so you can see them on the spoke. And since just as a groundwork to add this our national structure and how we deal with consent across it, as opposed to how MiHIN does it, which we've already learned, is that we have a membership agreement in place between the Commonwealth Health Alliance and our members. In that are some minimum terms. It kind of sounds familiar, which we require our member to pass through. Those minimum terms cover things like, I'll show you real quick, compliance with laws, use and disclosure of health information, patient consents, all the things you would expect to be in there. And then we are also modernizing those. We started off very organically with people sitting in a room, organizations coming together and becoming members and writing these agreements. There are paper contracts between each other, between the alliance and the members. And we're passing on actual EULAs to be passed through from the members to their customers. And now we're actually redoing our agreements. We're putting them online, which will make it easier with regards to those minimum terms for our members to pass them through to their customers via links in their existing agreements. So you agree to these terms and conditions and the alliance policies, and the alliance policies and those conditions are online via just a URL. I'll stop there. That's just a little bit of my background. Now I'm a healthcare IT attorney. What that means is I'm a software attorney and an IT attorney that happen to get into healthcare IT as well. So anyway, that's a quick overview and a quick overview of the Commonwealth. So when we discuss it from a panel, we can talk about the differences, the challenges that we're facing on a state versus nationwide basis, and then how those challenges can be addressed. So thank you.
Chanley, I'll turn it over to you to give a little bit of a background on your experience.
Sure. Thank you, Shreya. I'm Chanley Howell with Foley & Lardner. I'm in our Jacksonville, Florida office. And I've been practicing technology and data privacy and security law for 30 years. And I'm not 100% healthcare, but healthcare is a very large part of that practice. And it's, as we all know, it's such a big area for privacy and security. It's one of the main things that interests me. Did you want to introduce the next topic?
Sure. Since we're going to be doing a kind of a panel discussion for the rest of the healthcare privacy and consent session, I'm going to kick us off with a question, and then we'll have each of you spend some time going through your own experiences with that issue. So stigma and discrimination against persons with addictions led to the passage of 42 CFR Part 2 over 40 years ago. However, with so many opportunities to coordinate care effectively through information sharing, pressure has been building to modify this regulation so that information can be shared among providers more readily. Chanley, I'm going to start with you based on your prior experience with 42 CFR Part 2 to give everyone a little bit of a background on what it is, what are some of the positive aspects of it, some of the negative aspects of it, and if you see any future changes occurring with it.
We're going to have a little bit of a short little history lesson. We've been talking about a lot of cutting edge technology and a lot of futurists and a lot of good prognostication. But I think it's important to remember where we've been, because if you don't know your history and understand where things came from and things that worked and things that didn't work. If you don't understand that and have an appreciation for that, then it's going to be a problem going in the future. So it's nice to know your history. So 42 CFR Part 2, as you probably all know, deals with substance use disorder information, which over time has become very sensitive, and rightfully so. So back in 1972, there are actually 2 federal laws that were passed, one having to do with drug treatment, drug abuse treatment, and one having to do with alcohol abuse treatment, 2 separate laws. They were reconciled, and the regulators were required to make regulations dealing with handling the confidentiality and privacy of both drug and alcohol, now substance use information, which is what 42 CFR Part 2 is, that regulation. So the regulation came out in 1975. So think about where you were in 1975. What were you doing? What was your personal situation? But more importantly, what was your technology? Did you have any technology in 1975? I didn't. I've always been, to use Jeff's term, to geek out. I geek out all the time. I'm a technology lawyer. But in 1975, the first PC from IBM came out, the very first PC. Microsoft was formed, your former employer. It wasn't until 1989 that the World Wide Web, I say the World Wide Web, it's sort of funny to say that now, but back in '89, it was a term that everybody used. Now it's the internet. But as you probably know, internet was before, it was a Defense Department initiative, and then evolved. But the web as we know it today with hyperlinks was not invented until '89. And this law was developed in '75. The first web browser was the web was, quote, invented by Tim Berners-Lee. And he also developed the first web browser in 1990. It was called the World Wide Web, pretty ingenious name for the first web browser. In '93, Mark Andreessen developed Mosaic, the first, then it became Netscape. My point there is the law that we're dealing with, and the reason a big part of what we've been talking about today and the challenges of sharing health information, and particularly sensitive health information, and distinctions between different levels of sensitivity, is because we're interpreting laws, and as people have spoken about, and Tara mentioned, there's been revisions to Part 2 in '87, but again, think about technology in '87. And then 2017, and a couple of tweaks to that in 2018. So the changes have not been tectonic or a tremendous overwrite. They've been sort of tweaks. So that's the challenge. And my point is that going forward, that stakeholders like people in this room are going to need to push for change, because we're all in favor of interoperability. Yes, the reason Part 2, the laws in Part 2 were passed is because of the discrimination against drug and alcohol abusers, without a doubt, still exists today, and fear of prosecution. And with the opioid epidemic, which we've heard about today, it's now more prevalent than ever. I'm sure in 1975, no one predicted there'd be the opioid crisis that we have today. And to get the right treatment, there has to be sharing of information. So it's a huge friction between getting the right treatment, but also sharing of information. Because remember, at a baseline, HIPAA allows essentially sharing of protected health information for treatment without consent. But that's not the case with substance use information. 42 CFR Part 2 is more strict than that and requires express consent. Then you layer on top of that the state laws, which Tara talked about, and I think Jim will talk about a little bit more later, And it makes a lot of challenges that make treatment and care coordination more difficult. But we can't throw out, and I think probably, you know, I know a lot of you, I've spoken to a lot of you, I think we're all generally in favor of free exchange of information and interoperability. But I'm all in favor of that, but I acknowledge we can't throw out privacy. Can't throw the baby out with the bathwater. We got to acknowledge that. We have to protect privacy and security. So it's, as we've heard about all day, it's an ongoing discussion that we need to engage in, and that's why it's great that we're having this in the days to come. So fast forward to we'll go back to 2015, when SAMHSA, the agency that deals with 42 CFR Part 2, it's actually enforced by the Department of Justice, so it's a criminal, it can have criminal ramifications. But there's some factors that forced updates to the law, which, as I say, happened in 1987, and more, and what I'll talk a little bit about more in 2017, and then we'll keep things moving. But there were changes, there were factors that finally forced the updates. And, you know, myself personally, and some of my clients feel that SAMHSA didn't go far enough on allowing information exchange, but that's okay. We'll continue to engage in the conversation. But what forced the updates is the integrated care is now a concept that did not exist in 1975, didn't exist in 87 when there were changes. The concept now of, you know, ACO is an integrated care where you need to have exchange of information. And that leads to number two, the electronic infrastructure. There was no electronic infrastructure in 1975. When 72, when the laws were written, 75, when the regs were written, there essentially was no electronic infrastructure being used by, certainly no networks being used by providers. And there were also a lot of providers that provide, back when the law was originally written, generalized care or specialized care not in substance use disorder. And so they didn't get involved. Now there are general care providers that also will get into and have appropriate times to prescribe substance use disorder treatment. And so then there's the issue of, well, are you covered under Part 2 or not? And do you have to get the extra consent? So as I say, Part 2 is more stringent than HIPAA. So if it's Part 2 information, you have to follow Part 2. One of the big changes with the 2017 revision was the general designation. And previously you could have well, what I mean by that is that the consent for sharing substance use disorder information would have to state who the patient or who the provider can share the patient information with. Have to list the entity, could be a system or a hospital or a physician, but would have to identify who it gets shared with. That was changed. The old law said, well, for payment purposes, you could make a general designation, but not for treatment purposes. The new change made it, well, for treatment purposes, the patient could consent to what's called a general designation, which was a very big step. And it's primarily for the HIEs of the world, including the MiHINs and the network, as Jeff said and explained, it's a network of networks. But when you're in the ecosystem of organizations that exchange information, again, Jeff, the plumbing and the pipes, or if you're an HIE, a regional HIE, there was a lot of uncertainty about, well, can the provider, can the covered entity even share it with the HIE if the HIE is not indicated on the consent form? And then what can the HIE do? So long story short, the general designation allows a patient to consent to share my information with, for example, and this is in the reg, past, current, and future treating providers. So it doesn't have to name the entity, but it's really for use with HIEs in networks. If it's to a specific entity, it has to name the entity. But if it's to an entity with a non-treating relationship with the patient, it can be a general designation, which was a really big step. Again, I think there's more work to be done, further to go to facilitate exchange of information for substance use disorder. But that was a big step because now the patient could just indicate, you can share it with my treating physicians. That's, for example, would be an instruction to MiHIN or to MiHIN's participants, MiHIN's HIE participants. And that dropped a big barrier. So that was a very good thing. Now it is the patient's decision. Patient has to be given a decision. Can it be a general designation or only to specific entities? Also, the new rules clarify, well, how much control does the patient have over what gets shared? In a similar kind of concept, it can be all of their substance use disorder information, or it can be more granular, and the patient has to be given that choice. You know, so for example, medications could be allowed or disallowed, substance use history, allowed, disallowed, employment information, living situation. The patient can be given that granularity, has to be given that choice, or it can be all of it. Another thing that the new changes did is, as you may know, under Part 2 for the substance use information, when there's an authorized disclosure for treatment pursuant to consent, there has to be a notice to the recipient, so let's say to another healthcare provider, that this information is protected under federal law and cannot be redisclosed without patient consent. So just because patient consented to disclose to provider A does not mean that provider A can automatically disclose it to provider B. Again, a challenge to care coordination, but a protection for privacy, which is appropriate for consideration and discussion and working through the process. But what it did was, in this, again, is a nod towards the electronic exchange of information in HIEs. The prior redisclosure notice was pretty wordy, about 3 lines on a regular Word document. And the law, and you couldn't vary from that. The law changed that. It can be abbreviated. Now it can say federal law /42 CFR Part 2 prohibits unauthorized disclosure of these records. So that was another help in as far as disclosure. One other point, when for the networks who are, when there's a general designation, the HIE, and part of the law is, has to give and be able to give a list of who the information was given to. So that's just another requirement that was built in, where SAMHSA said, okay, you can make this general designation, patients can make that. But if a patient does, you also have to notify them of their right to get a list of everybody that you've disclosed information to. So that is a overview of what I think are the improvements for at least on the federal level on the substance use information.
I'll open it up to both Tara and Jim if you have any feedback on some of the challenges of 42 CFR Part 2, any potential solutions that you think to kind of solve this problem of care coordination, or any other thoughts.
Thanks. So I think the big thing that didn't happen in the update was that it still is required to comply with Part 2. You still need to get patient consent in order to disclose, even for treatment. So there's a big distinction between HIPAA, which permits exchange for treatment purposes without patient authorization, and Part 2. And certainly there are folks fighting hard for that change to be made. SAMHSA considered it in the preamble language, is not hiding from the fact that that's a request of many, but to date it continues to require that consent, and to base that on the continued discrimination, stigma, and concern that the stigma and discrimination will then result in some folks perhaps not pursuing treatment. When I first started this project for New Jersey, I wasn't, as I said, this was not the area in which I worked primarily, and I certainly wasn't engaged with many providers or patients. It was a much more sterile relationship. It was me analyzing the law, and it really seemed logical to me to align, to say, come on, this is for treatment. These individual professionals can keep the information confidential. Why don't we have alignment? It will permit so much exchange of information, which will then provide or permit better care. How can you make informed treatment decisions if you only have part of the medical record? But the more I got into it, the more people I spoke to on the ground, advocates for patients, and there is such a strong tension, right? So the idea of integrating the records and having full records, one of the goals of that is to improve care, right? Because you have more information, you can make better decisions, provide better treatment because you have all the information available to you. And that I certainly want to support. But when I hear from others on the other side of the debate, people who certainly want to have good care for individuals with substance use disorders, and they talk about the risk of patients not pursuing treatment because of the continued discrimination and stigma issues, the concerns of losing child visitation privileges, the risk of employment loss. I don't want to see people not pursuing care in this opioid epidemic. So it is a real, real tension that persists, and I think I spent a lot of time talking with folks in New Jersey in particular about how to resolve this, and there were folks who were working on data segmentation, I don't even know what to call them, programs. Again, I told you I'm not techie, but the idea that there's some way to say, okay, we're going to really protect this information but still permit the exchange of as much as possible. And most people that I spoke to said, we're just going to keep getting consent. It's too tricky. The data segmentation technology is not advanced enough. It's really hard with the narratives in behavioral health records compared to the much shorter fields in physical health records. And so I still am on the fence as to what to do. I'm not an expert on the advocacy and the patient treatment, but I do think it is much more complicated than just saying, don't we want to have all the information available to make treatment decisions? And so there is pending legislation. There's a bill pending at the federal level to permit the exchange of Part 2 information for treatment purposes without consent. I'm not reading the tea leaves. I don't really have a good sense. I'm sure some folks in this room might have a better idea of how likely it is that legislation will pass. So there is the potential to have this clarified at the federal level. Still have to worry about state laws that may be more protective, but I have retreated from my initial assessment, and I do think perhaps the better path forward is to work on streamlining the consent process as much as possible, so that we don't make the risk of hurting these patients and deterring treatment.
A good discussion and an important one, but I don't have anything to add to it. Good job.
No problem. As a kind of follow-up question to 42 CFR Part 2, are any of you three able to describe some ways that treatment programs, healthcare systems, HIEs or HINs are able to approach the challenges of sharing client information related to substance use disorder? I know Tara mentioned that consent was one solution. If nothing was to change with 42 CFR Part 2, perhaps we could streamline the consent process. Are there any other things that you can think of that could be a solution to sharing information?
Yeah, when Tara said about the consent, I think I agree. That's a big part of the solution, because the policy and legislative solution, the friction will always be there, privacy versus sharing. So the more you can make the consent, and it's not just consent, the law requires, and we all as a society want, informed consent. Again, not like the privacy policies on a e-commerce website that you click and don't read. That's not the way it should happen with your health information. So, I've worked with some clients on their electronic consents, and the electronic world provides so much more breadth and ability to have robust consent that I think there's a lot of opportunity to make it work well and then help grease the skids, oil the system to make it more efficient. So for example, you can do so much more education when you have electronic consent, because there can be links, for example, to FAQs. And by the way, this can all be done, and you may have experienced it or you may have dealt with it in your own organization. This, it can be done on a mobile device or an iPad, and it can be done by a patient sitting in a waiting room, where they don't have to be at their home in front of their PC. And this cannot be done in the paper world, but so e-consent, I think, is part of the big solution. Using technology to provide the information. There's really three things we look at. I'd look at, and I think the legal world from a perspective of e-consent is the education part, the technology piece, and then the legal compliance piece, and the electronics helps that. So as I mentioned, you can have links to more information about what they're consenting to. You can have questions in and at the end of a consent to make sure the patient understands what they're agreeing to. You can have surveys on the front end that will help, again, getting a little bit into the AI world, that get to the right patient consent form. So where if you picture, as I was talking about some of the consents and the requirements for substance use under 42 CFR Part 2, there's some granularity required. And that can be a little daunting on a paper form. And it can be very difficult for the patient to understand that. And nobody wants that, because if they check the wrong box, it's not good for them, it's not good for the provider. But it's a lot, we've all filled out online questionnaires where it walks you through step by step. If you do your taxes on TurboTax, it's a lot easier than reading all those IRS forms, or you could just give it to your accountant. But if you want to do it yourself, it really, to go question by question, have explanations, have links to information, it's frankly a game changer. There's technology now, and we have clients that are using QR codes where you can hold up, if you have an iPad provided by the healthcare provider, or if you have your own mobile device, you can be looking at a poster in a waiting room and hit the QR code and then see the additional information. Very, very useful. And then when a customer goes through or a patient goes through the online or electronic questionnaire, then it can send the proper form to the patient. Again, to do that on paper is extremely complicated and confusing. Now, the difficulties, I think, in the e-consent world are, a lot of technology today is moving to the cloud, and so there's challenges with that. I've seen surveys that CIOs of health systems are very, and I think rightfully concerned, to be worried about moving their PHI and other sensitive data to the cloud. That has to be worked through. And then I'll just mention in passing, I wouldn't be a privacy lawyer if I didn't mention GDPR, and probably, even though most people in this room are very US based, the GDPR, General Data Protection Regulation, it can impact your organization. So when we're talking about these issues, if you're dealing with information for EU residents, it's just another layer, another complexity to think about. But big picture, the regulations in the EU are stricter and stricter still now with the new law than in the US. And so it'll be continuing to push, I think, the US towards stricter data privacy and security laws.
I guess another topic which some earlier discussion made me think of, problems around consent across state lines. We know it's difficult to have interoperability even within one state between different systems. So if you're trying to implement an electronic consent model and you don't have interoperability across networks, that's problematic. When you go on a nationwide basis, it's even harder to solve because you have every state that might have different networks. So how do you solve technology and interoperability issues on a nationwide basis? The Alliance, the Commonwealth Health Alliance, had to tackle that. And a couple things that you use to tackle that. One is standards and APIs, two things that were mentioned before. Standards, they need to be, we license the Commonwealth Health Alliance standard under RAND-Z terms. That's non-discriminatory licenses, right? Royalty-free. So those specifications that are a map to how you interoperate with that network are licensed for free. And so nobody can take them and make them proprietary. So the key is to ensure you have proper standards that are well drafted and easy to comply with, that are created by the industry, and then you license them under a RAND-Z license. How do you deal with, or what's the tension between that and proprietary software? The Alliance has lots of members like Cerner, McKesson, who have lots of proprietary code they don't want to lose. Why are they willing to join that network? The key is to have that standard that has just enough interoperability related to IP to allow interoperability while allowing your members to protect their proprietary IP. But you have to have the right balance. When we were talking about search algorithms and things that a community might want to have to increase the effect of healthcare or outcomes of healthcare, you want analytics. So if you were a standard setting organization, you could, by putting it in your standard, that type of functionality, you can prevent that from being proprietary, but have it free and licensable to the community. So that's just what I wanted to address, that point that was raised earlier about how do you deal with that balance between IP and standards. And the other, somebody brought up their agreement that they had for Michigan, where they had a vendor who was putting, when they were offering services, and it was all proprietary, and that's what we call vendor lock-in. It's not just related to healthcare IT. Anytime you have a vendor and you hire them to help you provide your services, you have to be concerned with vendor lock-in. So that's where APIs come in. APIs, for those of you that don't know, those are application programmable interfaces. It's just a way for an application, think about it as your application that you want to use as an organization. You want it to, in order to have interoperability, you want to have APIs out there which are basically interfaces where other parties, say other networks or something, can connect through, and you have documentation and easy ways for those folks to connect through your APIs. So well-documented, well-developed APIs. So when you go out to RFP, say for somebody that's going to be a service provider for Michigan, or even if you're a private company, you have to mandate in that RFP that the deliverables include APIs that are well documented and that you can use regardless of what service provider you have. So I just wanted to address that concern that somebody brought up earlier. That's the way you deal with that. And also I heard APIs brought up, so I figured I'd mention that as well.
I hate to stop the discussion when it seems like we're just getting started, but in the interest of time, I did want to reserve at least 5 to 10 minutes for any questions that you have for the healthcare and privacy consent panel.
Long day.
Sure.
Work and efforts, thank you, and the importance of sharing data. And on the other hand, you've given fantastic voice to the reality of why it's important to be sensitive to stigma and the implications. And my hat's off to you, Tara, I believe. for your kind of self-divulged transition from initially kind of like, oh, I think we should share it, to now that I better understand the challenges, I think perhaps we need to focus in on consent. So I just wanted to thank you for that discussion. I think it was very thoughtful and important, and personally, I come to the same conclusions in my analysis with the different hats that I wear as well, so thanks.
Yeah, I think that's a good, very, very good comment, and I appreciate hearing that. And it's like a lot of the issues that have been talked about today, there's no easy, pat answer, but as long as there's discussion about it and civil discourse, and people, like everybody in this room that care about patient care and health, then eventually the right decisions will be made. So thanks for your comments.
Thanks. I just had a question about opioid use disorder patients, and I was at a conference recently, and they were talking about possibly, adding to an EHR some kind of like a functional sticker, so that when you're treating a patient, you can just see, oh, they've got a yellow sticker, so I want to be careful if I'm going to diagnose or if I'm going to treat them with an opioid. And following this discussion, Tara, I can understand that there is a lot of sensitivity from patients about something like that. But I wondered if in your discussions anyone talked about a middle ground where, maybe they would agree to having some kind of sign in their EHR or in their medical records to say this individual is sensitive to. Because I think of like an allergy. No one has a stigma if they have an allergy, but if they're addicted to something, there's a huge stigma, and that I think that's the reason for the whole change in away from using the term addict. We say opioid use disorder instead of abuse. So I wonder if there is a middle ground that anyone has come up with that makes patients a little more comfortable to maybe not divulge everything about their history, but to say, there's something that we should talk about if diagnosis or treatment would involve prescribing an opioid.
I haven't heard a specific proposal for a middle ground, but one thing that just is an alert for me, so I want to make sure it's out there. If it's a Part 2 program providing that information, that's enough to violate Part 2 to put some type of a flag, because you can't identify a patient as having been a patient. Even just calling a program and not being treated, I believe, is within the protections of Part 2. So I don't know what the source of the information would be to be able to generate the flag. If it's a non-Part 2 program, you don't have to worry about Part 2, but there could be a state law that protects that information. So apart from the policy discussion as to whether there's a middle ground, I just worry as a starting point it may not even be feasible, because it is disclosing a patient's past history, unless in fact it's some analytics that's predicting that they might be subject, then it's not based on actual treatment, but that's beyond me and my tech capacity to opine on that. Does anyone else agree that that might be a concern?
Yeah, I think that would be, if there's a flag that would tell other entities or treatment providers outside of the Part 2 program in the medical record, that would be a Part 2 trigger. So you'd have to get consent. But I mean, I think it's a good thought to pursue. It's something that I think maybe patients would be more willing. It's perhaps an option for the patient consent. So maybe they don't want their history of substance use, their 10 pages disclosed, but for other providers to know that there is just generally a history of opioid use. I think I could see patients being more willing to consent to that. Again, that goes to the granularity of consent that would be available electronically.
I concur as well. And I was thinking, I thought the same thing. One thought, though, it might be something that could lend itself to a private app, say, that somebody has on their phone. You get your heart rate and other health information. If you got a little red flag that said, watch out, you appear to be going down an opiate issue path, maybe that sounds interesting. But I would think that for something like that to occur, or any other kind of indication as a flag, generally it probably needs some change in regulations to have something like that.
Great, thanks so much. I'd like to thank these 3 panel speakers for sticking around until the end of the conference and giving such great insight on these topics.
Thank you.